and surgical pathology is thus confirmed, which says clear cell carcinoma. Small renal masses are defined as contrast-enhancing masses with largest dimension of 4 centimeter or less, a subset T1A tumors according to the TNM classification. The incidental detection has increased from 7 to 13% previously to 48 to 62% due to radiology performed for other non-related diseases. About half the patients are more than 65 years of age with significant comorbidities.
सिर्फ 9 रुपए में on Flipkart Minutes. आज आपको एक कहानी सुनाता हूँ.
Up to 20% of small renal masses lesions are less than 4 centimeters are benign, and 70 to 80% of them are indolent, and up to 40% lesions of less than 1 centimeter dimension are benign. Every 1 centimeter increase in size increases the risk of malignancy by 70%. Average growth of 0.31 centimeters per year, 37% may not progress. 67 to 74% renal cell carcinoma remains undetected till death. The factors that predict progression of a small renal mass include age. Patient with 75 years is more likely to progress. Patient having a size of 4 centimeters is more likely to progress as compared to a patient with 2 centimeters. An initial tumor volume of 66 cubic centimeter or compared to 15 cc is more likely to progress. A linear growth rate of 8 mm versus 3 mm. 8 mm tumors growing 8 mm or more are more likely to progress. Similar with volumetric growth, tumors growing more than 27 cc per year are more likely to progress as compared to 6.2 cc. Now comes the need of biopsy. As we discussed, 20% small renal masses are benign, and 60% are indolent cancer, and only 20% are potentially aggressive. Benign may be put under active surveillance, and indolent cancer, a patient with significant comorbidities may be put under active surveillance or may undergo thermal ablation. For potentially aggressive cancer, we use partial nephrectomy or radical nephrectomy. The indications of renal mass biopsy. Traditionally, small renal masses indeterminate on radiology were considered. If there was a possibility of lymphoma or renal abscess, we would consider biopsy. Masses with suspicion of metastasis, a biopsy would be considered. Incidentalomas in patients who are candidate for active surveillance or ablative therapy, and follow-up for thermal ablation, and to monitor recurrence of a previously operated patient. Now, these indications have been expanded due to renewed interest in modern imaging and image-guided biopsy. There is increased expertise of the intervention radiologists and pathologists, for which these biopsies, so we perform more biopsies now, and we can avoid surgery in approximately 16 to 17% of the patients. The procedure uses image-guiding ultrasound or CT scan. An 18-gauge needle with minimum 2 pores is required. We need to avoid the central necrosis and cystic masses. Use of immunohistochemistry has proven a lot of benefit. HMB45 is seen in fat poor AML. Cytokeratins are used to differentiate oncocytoma versus chromophobe RCC. And as discussed earlier, carbonic anhydrase 9 significantly expressed in a clear cell RCC can be used. Goals for management of early stage renal cell carcinoma are improvement of cancer-specific survival, preservation of renal function, avoidance of treatment-related morbidity, and patient-centered quality of life outcomes. We have basically 4 treatment options for patients with localized RCC. These include radical nephrectomy, partial nephrectomy, thermal ablation, active surveillance. Active surveillance is a few patients are excluded, such as young and healthy patients, patients with variant histology such as sarcomatoid, collecting duct, or unclassified RCC, high-grade patients with high-grade tumors, and symptomatic patients. Patients that need to be included are patients with benign lesion, an aged and informed patient. Size of the lesion should be less than 4 centimeters. There should be no aggressive features. It should be a low-grade tumor on biopsy. Chromophobe or oncocytic hybrid tumor. Willingness for regular follow-up with imaging. A patient who is a poor surgical risk and limited life expectancy. A protocol biopsy may or may not be performed first, but we usually prefer performing a biopsy. CT or MRI is done every 3 to 6 months for the first 2 to 3 years, followed by USG or CT or MRI annually for 5 years. Annual chest X-ray is to be done if the lesion is biopsy probe. When to stop? According to the AUA guidelines, if the diameter is more than 3 centimeters, we need to stop. According to the ASCO guidelines, when the diameter is more than 4 centimeters, we need to stop. Both suggest a growth rate of more than 0.5 centimeters per year. We need to stop active surveillance and go in for surgery. If there is increase in stage on subsequent follow-up and there is evidence of metastasis. Disadvantages are there is a real metastatic potential of these tumors, potential longevity variable and not accurately predictable in all the patients. The cost of frequent surveillance studies in a resource-poor country like India may negate the need for active surveillance and anxiety of the patient. Coming over to surgical management, nephron-sparing surgery or partial nephrectomy forms the cornerstone of management of patients with localized RCC. Preoperative evaluation, all patients should be evaluated prior, which include a detailed history and physical examination, lab investigation as we discussed earlier, radiological testing to rule out extensive metastatic disease and a chest X-ray. And partial nephrectomy in particular requires a more detailed understanding of renal anatomy than radical nephrectomy. Therefore, more extensive and invasive preoperative imaging are often obtained before partial nephrectomy, which may include arteriography, venography, or a CT angio. Arteriography is useful for non-peripheral tumors encompassing 2 or more renal arterial segments. Selective venography is performed in patients with large or centrally located tumors to evaluate for intra-renal venous thrombosis and assess adequacy of venous drainage of the planned renal remnant. Differential renal function may also be assessed in some patients and can be assessed by isotope renography. And patients should receive organism-specific antibiotic therapy preoperatively via culture sensitivity. Role of CT angio. It plays a vital role in preoperative planning. It determines the number of vessels directly supplying the tumor and aids in surgical decisions. A 3D volume rendered CT gives the renal parenchyma and vascular anatomy, also demonstrating involvement of the collecting system. This is an image of a 3D volume rendered CT. It shows tumor in the upper part with the renal arterial and venous supply. A small video clip of how we generate the 3D image. There is a subtract. First, an image is generated across the CT. Then we subtract the area of interest and further utilize the softwares that we have to accurately study the vasculature, which can be seen on the axial sections of the CT, the tumor corresponding. We further subtract these other vessels that are not useful for us and particularly render the 3D model that is preferred, which can help for further decision of the surgical management. 3D printing gives us models to practice on beforehand, and 3D printing can be utilized with the 3D rendered CT. It improves preoperative planning and betters the outcome of surgery. As we can see in the lower image, the tumor is located in the upper pole along with the various vasculature, which has been very well shown. And we can plan beforehand where to clamp and where exactly what excision area is required. Scoring systems, various scoring systems are in place. The renal nephrometry system, the Padua system, the DAP diameter axial polar nephrometry score, the ABC arterial base complexity. Of these, the most commonly used is the renal nephrometry score, which has a total score of 12. It includes the renal, that is the radius in centimeters, less than 4 centimeters, 4 to 7, and more than 7. Exophytic, endophytic properties, more than 50% exophytic, less than 50% exophytic, entirely endophytic. Nearness of the tumor to the collecting system or sinus in millimeters, more than 7 is a score of 1, between 4 to 7 and less than 4. Anterior or posterior is designated by A or B, and location relative to the polar lines, whether the tumor is entirely beyond the polar lines or the lesion crosses the polar lines, or more than 50% of mass is between the polar lines. The scores based on nephrometry system, the complexity is low, intermediate, or high. Scores with 4 to 6 are low complexity system, low complexity tumor, intermediate are 7 to 9, and high complexity is 10 to 12. Partial nephrectomy is in which uninvolved portion of the kidney is preserved after removal of the tumor with a small rim of normal parenchyma. It has been performed electively for other patients with solitary renal masses, or oncological outcomes are comparable to those of radical nephrectomy. Recent evidence suggests that patients undergoing partial nephrectomy survive longer than those undergoing radical nephrectomy, perhaps due to greater preservation of renal function. There are some absolute indications for nephron-sparing surgery, which include a bilateral renal cell carcinoma, RCC in a solitary functioning kidney, irreversible impairment of contralateral renal function by benign disorder. Relative indications are when the other kidney is suffering from a medical disease such as renal artery stenosis, hydronephrosis, chronic pyelonephritis, a ureteric reflux, calculus disease, or a systemic illness such as diabetes and nephrosclerosis. Elective indications in tumors up to 4 centimeters with normal functioning opposite kidney, or a larger tumor with significant parenchyma remaining after surgery, a partial nephrectomy may be performed. Basic principles include early vascular control, avoidance of ischemic renal damage, complete tumor excision with free margins, precise closure of the collecting system, careful hemostasis, closure or coverage of the renal defect with adjacent fat, fascia, peritoneum, or oxycillosurgical. Intraoperative renal ischemia, temporary occlusion of the renal artery is necessary in nephron-sparing surgery. Temporary occlusion not only diminishes intraoperative renal bleeding, but it also improves access to the intrarenal structures by causing the kidney to contract and by reducing renal tissue turgor. There is better visualization of the tumor extent. Complete tumor resection without healthy margin can be done, and easier closure of parenchyma can be done. There are various methods of clamping. We may clamp the main renal artery. We may need to clamp the entire pedicle, including the vein. We may only clamp the affected segmental artery. And we have now come to off-clamp partial nephrectomy or zero ischemia partial nephrectomy, where there is no clamping, but a selective microvascular dissection is done to the vessel, and the vessel ligated is just that which is supplying the tumor. Now coming over to the concept of warm and cold ischemia. Cellular degeneration begins in proximal tubules 20 to 30 minutes after clamping, and complete cellular degeneration occurs after 60 minutes. Warm ischemia should ideally be less than 20 minutes, and 20 to 30 minutes is a gray zone. Surface cold ischemia with medulla at 22 degrees Celsius is not tolerated for more than 60 to 70 minutes. The various methods of cooling that we have are surface cooling and transarterial cooling. Surface cooling is more commonly performed, laying ice slush or cold saline around the kidney. After exposure of 10 minutes, a safe cold ischemia time of 35 minutes can be achieved. Transarterial cooling, perfusion through clamped renal artery with cooled lactated Ringer solution. Kidney is cooled to 5 to 10 degrees Celsius. It minimizes damage by abrupt switch of renal cells from aerobic to anaerobic respiration. Prevention of ischemic renal damage is done by preoperative and intraoperative hydration, avoidance of unnecessary manipulation or traction on the renal artery. Intraoperative administration of mannitol can be given, and induced hypotension also has shown benefit. These factors ensure optimal perfusion with an absence of cortical vasospasm at the time of arterial occlusion, which allows uniform restoration of blood flow throughout the kidney when the artery is unclamped. Mannitol is most effective when it is given 5 to 15 minutes prior to arterial occlusion. It increases the renal plasma flow, decreases intrarenal vascular resistance, and minimizes intracellular edema, and promotes an osmotic diuresis when renal circulation is restored. Other protective measures that are used are local hypothermia. Lowering the renal temperature reduces energy-dependent metabolic activity and shifts the cell from aerobic to anaerobic. Optimum temperature for hypothermia in situ renal preservation is 15 degrees Celsius. Factors that have increased partial nephrectomy in RCC are the advances in renal imaging, as we discussed, like CT renal angio, 3D rendered CT, and 3D printing models. Various improved surgical techniques such as robotic surgery, which has improved outcomes and better tumor excision. Increased number of low-stage RCCs detected incidentally, and a good long-term survival. Timing of surgery in bilateral RCC. There are three options. We can either perform partial nephrectomy of the more favorable tumor, followed by partial or radical of the non-favorable tumor within 6 weeks. A radical nephrectomy of the more aggressive tumor first, followed by partial nephrectomy, or we can do a simultaneous surgery. It is completely based on the clinicians and patient's condition. Coming over to the types of partial nephrectomy: simple enucleation, polar segmental nephrectomy, wedge resection, transverse resection, and extracorporeal partial nephrectomy with renal autotransplantation. This is a simple enucleation of the tumor. The tumor is enucleated, followed by a complete suturing of the PCS system, various renal veins and arteries, and followed by nephropexy of the remnant kidney or renorrhaphy. Segmental polar nephrectomy, tumor confined to a particular pole, we can ligate the polar branch first, followed by a line of demarcation which is formed, and we can cut along that line. In wedge resection, it is similar to enucleation, where the wedge of kidney, in enucleation we just enucleate, in wedge we remove a wedge of kidney, followed by the PCS closure and renorrhaphy. Transverse resection, in which there is a large upper or lower polar mass, where we can ligate 2 or 3 segmental vessels, and following which a line of demarcation comes on, which can be then used to do a transverse resection. Extracorporeal partial nephrectomy was described by Callan in 1973 and Gittis and Mikolo in 1975. It is indicated in large complex tumors involving the renal hilum. The advantages are it gives us optimum exposure, a bloodless surgical field, maximum conservation of renal parenchyma, and greater protection to the kidney through prolonged ischemia, not through non-prolonged ischemia. The disadvantage is a longer operative time needed for vascular and ureteral anastomosis. There may be increased risk of temporary and permanent renal failure. It is performed through a single midline incision. Kidney is mobilized and removed outside the Gerota's fascia with ligation and division of the renal artery and vein. The removed kidney is flushed with 500 ml of chilled intracellular electrolyte solution, submerged in ice plus saline solution to maintain hypothermia, just like we do in a renal transplant surgery. Following which the tumor is excised ex vivo, and then the kidney is the renography is done, making sure the continuity is maintained. Following which the kidney, along with the vessels and ureter, is auto-transplanted. Coming over to hypofiltration injury, it is seen in patients with solitary kidney who undergo partial nephrectomy. Patients with reduction of more than 50% of normal parenchyma or more are at more risk. Afferent arterial dilatation and or efferent arterial constriction is the main cause. The pathology seen is proteinuria and focal segmental glomerulosclerosis, followed by progressive renal failure. Treatment includes dietary modifications such as low protein diet, ACE inhibitors, or angiotensin receptor blockers. A small video of robotic partial nephrectomy. We identify the tumor first, and then we move on to the hilum in beyond the Gerota's fascia. The hilum is dissected to first nephrectomy. The renal vein along with gonadal vein can be seen clearly. Renal vein is identified. This particular case, there were two renal veins. The renal vein is identified and looped, but not regularly clamped. After identifying the renal vein, the renal artery is dissected. After identifying the artery is freed from the posterior attachments and all the adhesions. Once we have the artery in hand and the vein in hand, we then move on to the tumor delineation. The tumor delineation and the tumor is the tumor is demarcated, and following which, along with some portion of the fat of the Gerota's fascia, is kept along with the tumor. After marking on the tumor margins, we further proceed with cutting of the enucleation or resection of the tumor, whichever we feel more feasible. Here the renal artery is now being clamped, and a warm ischemia time thus starts, which is to be kept less than 20 minutes ideally, and 20 to 30 minutes is a gray zone. This helps in a bloodless dissection of the tumor. As we can see, there is relatively very less blood loss. The assistant plays a major role in this case as a regular suction and irrigation is required. Here the complete tumor has been excised, and we can see there is certain injury to the PCS which needs to be closed completely. So the first layer closure is done, which includes the PCS closure, usually done through a braided suture. Auto-locking sutures are preferred as they lessen the time of the surgery and thus reduce warm ischemia time. Following the first layer closure, we do the renography. In this, we use the sliding clip technique, which has gained a lot of popularity. Hemolock clips are used, which reduce the force exerted and help aid in proper closure of the parenchyma. The renography is complete and the clamps are removed, revealing a bloodless surgical field, following which the tumor is removed through an endobag. Coming over to radical nephrectomy, it was the gold standard curative operation. It was described in Robson in 1963. By Robson. Surgical principles are early ligation of the renal artery and vein, removal of the kidney outside the Girota's fascia, removal of ipsilateral adrenal gland. Now it is not the standard, and complete lymphadenectomy from crus of diaphragm to aortic bifurcation, again, which is not standard now. Radical nephrectomy presents an overkill even when adenectomy and lymphadenectomy are not performed. There is significant negative impact on renal function, which may lead to CKD and may be the cause of increased morbidity and mortality as it increases the cardiovascular risk factors. CKD may be present in more than 30% of patients undergoing radical nephrectomy prior to surgery. Laparoscopic or robotic versus open radical nephrectomy. Lap and robotic surgery have advantages, but widespread use for small renal masses has been proven detrimental, as many of which are amenable to nephron sparing surgery and permit greater preservation. But due to ease of radical nephrectomy through lap, a lot of radical nephrectomies are being performed. AUA guidelines are to be followed. Radical nephrectomy is only performed now if there is high tumor complexity, and partial nephrectomy would be challenging. There is no pre-existing CKD or proteinuria. There is normal contralateral kidney and new baseline GFR of greater than 45 ml per minute, even if radical nephrectomy performed. Otherwise, partial nephrectomy should be considered in all cases. Coming over to the next modality, which is the thermal ablation. It is used in patients with advanced stage or patients with significant comorbidities or patients with local recurrence after previous nephron sparing surgery, multifocal tumors, and for solid renal masses which are less than 3 centimeters, percutaneous approach is preferred. Cryoablation is the most widely studied method of ablation. The first known report of renal cryotherapy was by Ojeda et al. In 1995. It's an energy-based tissue ablation. One of the most studied ablative techniques. Aim is to achieve a targeted destruction of a predetermined volume of tissue, tumor, and a surrounding margin of healthy parenchyma. It can be done via laparoscopic or percutaneous approach. Various modalities are available and differ in the type of ablation energy. The mechanism of energy is the targeted tissue is rapidly frozen in situ, followed by sloughing of devitalized tissue and healing by secondary intention over time. The essential feature is a rapid freezing, slow thawing, and repetition of the freeze-thaw cycles. It is a result of the cytonecrosis, is a result of two-step process: rapid intracellular ice formation and delayed microcirculatory failure during the thaw phase of the cycle. A cryoprobe, we can see a cryoprobe of 3.4 mm and a cryolesion diameter created along the probe. The maximum temperature achieved is minus 51 degree or minus 95 degrees Celsius at 5 minutes. The indications are small lesions less than 4 centimeters. Larger lesions may require 2 or more probes. It is technically difficult and might leave a residual tumor. Solitary lesion is better for cryoablation when the lesion is located away from the collecting systems and in elderly patients. Contraindications include coagulopathy, significant postoperative additions from previous surgery, intrarenal or centrally located tumor. The technique may be open laparoscopic or percutaneous. We require a real-time imaging of the tumor. CT or MRI have not proven modality for detection of progression of the ice ball. Ultrasound with color Doppler is the most promising modality. We need to pre-plan the angle and depth of the probe. Needle biopsy of the tumor may or may not be performed, but it is usually preferred. We insert the cryoprobe through the center of the tumor at advance up to or just beyond the inner margin of the tumor. Cytolesion should be 1 centimeter larger than the tumor and should include a 1 centimeter rim of healthy parenchyma. We use lab USG or MRI compatible cryosystem for the percutaneous route. Argon gas causes rapid freezing at the tip of the probe, temperatures reaching minus 80 degrees Celsius. Helium gas releases heat as it is depressurized, causes rapid thawing. 2 freeze-thaw cycles are a must for any cryotherapy. This directly causes dehydration, damages enzymes, cell organelles, and cell membrane, and intracellular ice formation. Indirectly, it causes microvascular damage, causing hypoxic microenvironment. Picture demonstrating what we actually do. A retractor is used to pull the kidney towards our cells, following which the cryoprobe is inserted, and conical tip must be positioned at or just beyond the margin of the tumor. An ultrasonic guidance for cryoprobe positioning is obtained by placing the probe to the opposite surface of the kidney. Complications are urinary fistula, postoperative hemorrhage, injury to collecting system, and injury to the adjacent structure. RFA. It works through the radio frequency waves, causes friction of water, heat, releasing heat, and thus destroying the tumor. Cell death resulting from RFA begins 5 minutes of exposure to temperature of more than 50 degrees Celsius. Homogeneous RFA electrode temperature is usually between 50 to 100 degrees Celsius. It again may be laparoscopic or percutaneous. It can be performed using a dry or wet technique. In wet technique, the hypotonic saline is used, which promotes the centrifugal dissipation of the RF energy, resulting in a rapid creation of larger radio lesions without early tissue desiccation, as which is seen in the dry type. Ultrasound, CT, or MRI is used to roughly monitor the boundaries. So if you move. The RFA results are, they may be a wet or a spherical non-enhancing lesion is seen and gradual contraction scar. There is less data as compared to cryoablation. The future trends are extracorporeal high-intensity focused ultrasonography, radiation therapy using cyberknife or microwave therapy, and laser interstitial thermal therapy, chemoablation and combined chemoablation and targeted endovascular ablation. These are still under study. One more important thing that we need to cover is about the follow-up for the patients managed with partial nephrectomy or radical nephrectomy. Low risk follow-up should be yearly with CT or MR for 2 years, after which ultrasound may be considered. Intermediate risk follow-up is 6 monthly with CT or MR for 2 years, after which ultrasound may be considered. In high-risk patients, we need to follow them up 6 monthly with CT or MRI for 3 years and then annually. Very high-risk patients need to be followed up 3 monthly with CT or MRI for 1 year and 6 monthly for 3 years, then annually. For patients undergoing ablation, we need to follow them with pre and post contrast cross-sectional imaging within 6 months, and followed by the follow-up as suggested for intermediate risk group, which is 6 monthly for 2 years, and then USG. Thank you.
Thank you, Raghav. Quite exhaustive kind of a presentation on localized RCC. Again, a very important topic, also from theoretical point of view, from exam. Plus, we are getting a lot of these patients now, and half of the patients are now incidentally detected. We all know there was a triad, which was hematuria, renal mass, and pain. So, which is almost not very common nowadays. So, majority of these renal masses localized are detected on incidentally imaging studies, right? So it's important to understand that the two basic categories of localized renal masses, the SRMs, which are the small renal masses, enhancing less than 4 centimeter solid lesions are SRMs, and they include T1A lesion and Bosniak type 3 and 4. So when you said that the contrast enhancement should be there in every patient is probably not correct. The definition is enhancing lesion, usually more than 20 HU values, with or without contrast enhancement. So that's why it contains even the benign lesions, which are 20% of these are usually benign, and 60% would be indolent, which are not very aggressive, and 20% are aggressive, right? Again, if it is less than 1 centimeter, the treatment is usually active surveillance, 1 to 2 centimeter gray zone, more than 3 centimeter, usually you proceed with partial nephrectomy, and 2 to 3, you have to find out whether what is the growth, what is the size of the tumor, if it exceeds more than 3 centimeter on surveillance, or if it is more than 0.5 centimeter per year growth, then you would consider doing a partial nephrectomy rather than active surveillance. So definitely the diagnosis part is once you either you find it on imaging, or if you are suspecting these masses, then imaging, physical examination, as you said, they usually do not have any physical positive finding, whereas if CT or MRI would be probably the most important imaging study. And because we are more familiar with CT, probably CT we usually do in most of these cases CT scan. Metastatic workup should be done in every patient, and that we have already discussed. So once you diagnose a case of RCC, then definitely you need to stage this disease, which stages we know the TNM staging, T1, A, B, 2, A, B, and then the 3, A, B, C, and T4. So these are all very important, and the node, whether they are present or not, again, is very important. Only patients who have a localized RCC with single metastasis, again, the treatment could be a partial nephrectomy with metastatectomy or a radical nephrectomy with metastatectomy, and it gives almost a cure in most of these cases. Otherwise, we have to treat it accordingly. So once you have done a local staging, a risk stratification is again very important. We have a lot of calculators, UCLA calculator, the Mayo Clinic calculator, etc., which will give you the chance of recurrence in these patients and whether a particular adjuvant therapy is required in a particular case or not. So usually patients who have a high intermediate grade and a high grade disease, high grade is when a high risk disease is one, which is T4, or when the node is positive, N1. And high intermediate is when it is T3, or it's a T2 with the grade 4, Fuhrman's grade 4, or a sarcomatoid variety. So all these are considered as high intermediate grade. So all the high intermediate grade and high risk disease patients would require adjuvant therapy, which was probably missed in this. And nowadays, the recommendations are very clear that in this high risk and disease group, you give pembrolizumab 3 weekly cycles, and for 1 year, that is about 17 cycles in a year, right? Pembrolizumab. So that has been the standard of care now. Rest of the patients with low and other low risk, low grade intermediate risk would not require any adjuvant therapy. I think that was, and then you have discussed about the follow-up of these patients, which is again very important, how to do the imaging study every year. And at least for 5 years, the patient should be followed up, and urine examination for hematuria, proteinuria, and the symptoms. Then there was something about the ablative therapy. We have cryoablation, radiofrequency ablation, and microwave is not future. Microwave, we already have in our institute microwave ablation, which is being done routinely. So microwave ablation is there already. Probably it scores a little higher than the radiofrequency ablation and the cryo ablation. So, and then the HIFU has also come up now, and it is in the market available. It is again not future. The future probably there's something that you discussed about the laser and the cyber knife. Those are probably not still clinically practiced, but all these three are usually we do in most of these patients. So I think there is a role of and the role of biopsy is again very important. When would you do a biopsy? Biopsy in SRMs usually has to be done when the patients are put on active surveillance or we are doing ablative therapy. And then for monitoring these patients, biopsy is important. Otherwise, biopsy would be done in patients who have a kind of a doubtful kind of whether we want to differentiate between benign or sometimes lymphoma or abscess and metastasis. So these are the various specific indications for biopsy. Otherwise, usually we will not do a biopsy in a localized RCC. I think that was it brief, the summary. I would request our residents and faculty, if you want to make any comment or if you have query, please go ahead. Otherwise, we will continue with the MCQs. Dr. Nachiket, would you like to make any comments?
It was a great question. I think that the only thing that was lacking from making it a sexy presentation was that data about the survival and comparison of radical effect of 10-year data and 20-year, which is commonly presented now, especially memorial slow patient.
Yes.
They have actually given data for 20 years and they've divided it in the first 10 years and the next 10 years. So the thing that was lacking about this was maybe, because volume and data speaks now. So maybe if you can quote it, those articles which are quoted now about partial nephrectomy and how, they're better than radical nephrectomy in this group of patients. Especially that study, I mean, when we go to conferences,
All right. So Dr. Nachiket says that, yes, it would have been better if we could have included data, survival data of partial nephrectomy and radical nephrectomy. Yes, this could have even improved. But we know now that partial nephrectomy is the standard of care unless it is contraindicated. Right.
It's important for them to
give the data. Right. It's very, very important. Very important. And yesterday only we did a case on Saturday when the mass was about 20 centimeter big, right? 20 centimeters big mass, which was almost totally exophytic. And so we could do a partial nephrectomy in a tumor which was almost occupying whole of the half of the abdomen. So yes, though probably it could be sarcoma, biopsy is still yet to arrive. So it could be probably sarcoma. Yes, yes.
The second thing is that now, based upon these studies, even though the recurrence rates are slightly higher, partial nephrectomy, but now it does not affect the overall survival because they are salvageable by other techniques like resurgery or prior ablation. So this is also data which has come from this 20 years, 25 years study. That even though if there is a recurrence, but our overall cancer survival is the same as a radical nephrectomy. So this is also important to bring up, right? Because the only thing that you have in mind is maybe a recurrence, but they are salvageable.
Yeah. So so usually, if you are doing a good partial nephrectomy, one thing more about partial nephrectomy, you told about the various techniques, the excision, the wedge excision, the heminephrectomy, and the enucleation. But majority of this partial nephrectomy nowadays is a combination of excision and enucleation. So usually you start with a margin of renal tissue, and as you go deep, you enucleate the tumor. So this is a combination of enucleation and excision in majority of patients. It's not a single technique, right? And yes, if it is done properly, probably the chance of recurrence is very low in a patient who are not syndromic, right? Patients who are syndromic, we have to detect, we have to know exactly, and there the chance even after radical nephrectomy would be there on the contralateral side. So it is important to find out which are those syndromes, VHL, tuberous sclerosis, papillary variety, and all these have to be seen so that we need a closer follow-up in these patients and take these tumors out as soon as they appear. So we go to the MCQs. Question number 1, what defines stage 1 renal cell carcinoma according to TNM staging? Tumor less than 4 centimeter limited to kidney, 4 to 7 centimeter limited to the kidney, tumor more than 7 centimeter but confined to kidney, tumor extends into renal vein or perinephric fat. Stage 1. A, less than 4 centimeter. Though tumor, by definition, 1 is less than 7 centimeter. By definition, tumor T1 is less than 7 centimeter, which is again divided into 1A and 1B. Less than 4 is 1A, less than 7 is 1B. I think it should be less than 7 centimeter. Probably the question answers are the options are not correct. It should be tumor less than 7 rather than between 4 to 7 centimeters. So I think there is something wrong here. Stage 1, just confirm whether
Stage T1 is wrong.
T1
asking for T1. Or is the answer there T1?
Stage 1. 1 is probably, I think, includes T1. So stage 2 is T1B. T1B is stage 2. Let's confirm it. Somebody confirm it in the TNM classification. Yeah. Because nobody actually, we always do a TNM staging rather than stage 1, 2, 3, 4. So yes. What is the standard surgical management for a stage 1, that is T1A, a renal tumor in a healthy adult? Radical nephrectomy, observation, partial nephrectomy, radiation therapy. So partial nephrectomy is the treatment of choice. Preserve renal function. Which imaging modality is most commonly used for initial evaluation and staging of RCC? Ultrasound, X-ray, contrast, and CT, MRI. Staging, MRI, contrast, and CT. Which of the following is a relative indication for radical nephrectomy over partial nephrectomy in stage 1 RCC? Centrally located tumor, solitary kidney, bilateral tumors. So definitely centrally located. So many people would not be very comfortable with hilar tumors doing a partial nephrectomy. So that could be considered as relative, but nowadays hilar tumors are easily done by robotic. Robotic assistance has really made it simpler. What is the primary goal of partial nephrectomy in stage 1 RCC? Reduce cost of treatment, avoid surgical complication, achieve oncological cure with renal function preservation, shorten hospital. So definitely C, you achieve oncological cure with preservation of renal function. A 58-year-old man is found to have a 3.2 centimeter enhancing mass in the upper pole of the right kidney on contrast and has CT incidentally discovered during imaging of back pain. His eGFR is normal and is no significant comorbidities. What is the most appropriate management for this patient? So radical nephrectomy, active surveillance, partial nephrectomy, radiation therapy. So 3.2, definitely partial nephrectomy if everything is okay. A patient presents with a renal mass suspicious of RC imaging suggests a 7.5 centimeter lesion confined to right kidney. You are shown an image of tumor compressing nearby structures but not invading them. Which of the following factors would most strongly influence prognosis in this localized RCC? Tumor laterality, histological subtype, presence of flank pain, patient's BMI. So histological subtype, right? Subtype. Clear cell versus papillary versus chromophore has the most significant prognostic impact in localized RCC. A 65-year-old man underwent partial nephrectomy for a 3.5 centimeter renal mass. Pathology confirms clear cell RCC, Fuhrman's grade 2. So again, when we are talking about grade, usually nowadays we will have both isograding and Fuhrman's grading. So don't only just stick on Fuhrman's grading. Usually nowadays, most of these calculators will have both the systems. What is the appropriate follow-up? No further follow-up is required. Adjuvant chemotherapy, surveillance imaging per protocol, and radiation therapy to surgical bed. So surveillance therapy per protocol. I think, thank you. So can I just, okay. Something wrong with your, okay. So thank you. Thank you once again. Anybody who has joined us today wants to make a comment can raise his thumb, or from the residents and faculty. Participants, there are all, so we do not know. So people, okay, whatever it is. So if nobody has raised, we will just wind up the session, and I wish you all a good day. Thank you very much.